So let's talk about shoulder injuries in the workplace. Obviously, I've been doing this for a long time, so I'll try to share some of the things that I've found interesting over the years. And from a disclosure standpoint, I am the president of the Arthroscopy Association, and I consult for Arthrex, and none of that should affect this talk. So the shoulder, let's start with some anatomy. So the shoulder is by far the most interesting joint in the body, although I am prejudiced. Bias, I should say. So it has the greatest global motion, but it gives something up, and what it gives up is bone stability. The glenoid is only 1/3 the diameter of the humeral head. So it really depends on the surrounding layers of support and function. So the power comes from the deltoid. The anterior, lateral, and posterior deltoid basically elevate the arm in all of those three different directions. But in order to do so, though, the rotator cuff provides dynamic stability. In other words, it sucks the humeral head into the socket so that the deltoid can elevate the head. Otherwise, the humeral head rises up, which shortens the deltoid, and they can't elevate. And that's what you see with rotator cuff tears. Static stabilities, that means fixed stability, is supplied by the labrum and the capsule or ligaments. The insertional footprint of the rotator cuff, we looked at that quite a while ago and reported on in 2006. So the subscapularis is the front major tendon. The footprint is large. It's the largest of the cuff tendons, comma-shaped from the 7 to the 11 o'clock position, the blue area that you see there. Its length is about 4 centimeters. Its width about 2 centimeters. And it tapers from the interarticular portion, which is tendinous, that we see in the lower picture there, to just muscle and capsule inferiorly. And since all muscles ever do is shorten, the subscapularis internally rotates the arm. The supraspinatus is third in size, but it's important because it's the most affected by pathology in the shoulder. It inserts from the biceps groove back to the bare area, and that's the green area there. In the normal shoulder, it's tight to the articular surface. Posteriorly, it blends with the infraspinatus. That's the red area. The infraspinatus is the second largest cuff tendon. It wraps and interdigitates with the posterior aspect of the supraspinatus, and it's really important because, especially as I said, all a muscle can do is shorten. So if you think about where that muscle runs in the back, what does it do? It externally rotates and it elevates the shoulder. So you could lose your supraspinatus and still have decent function. The teres minor is the smallest muscle tendon unit. It's from 3 to 5 in the back, and it basically just externally rotates the arm with the elbow at the side. And so this is looking at a right shoulder. We're looking from an arthroscope. That cannula there is about the size of a pencil. And so it gives you an idea of a size. It's pointing at the subscapularis. That's the glenoid below, the humeral head above. The patient is lying on their side. That's the biceps, and that's the supraspinatus, and that's a normal appearing supraspinatus. As we go posteriorly, that's infraspinatus, and now we're looking at the inferior capsule down there. And there's no arthritis there. That's a normal area where it doesn't have cartilage, and that's called the bare area, but that's normal. And so now if we pull out and go up above, now we're in the subacromial space. So now we're looking down at the cuff and up at the acromion. And this patient had bursitis. That's all that fluffy stuff there, and impingement beneath a thick coracoacromial ligament above. So all this lady's pain was really reaching to the side and to the overhead. The labrum is important because it deepens the socket and basically provides stability to the shoulder. And so here we are now again looking at a left shoulder now. So there's the anterior inferior glenoid ligament. That's the labrum right there, kind of a diminutive labrum, but it comes up to the front of the shoulder. And in instability, when someone dislocates, that's what's ripped off. That's the posterior labrum and the inferior capsule there. And as we come up above, we'll see again in a second the biceps. That's the humeral head. And the biceps is superior. So that's basically the anatomy of the shoulder. So what causes trauma? What causes injuries to the shoulder? So of course, falls, motor vehicle accidents, that's causes traumatic issues. Lifting something too heavy, hanging or stretch injuries where you slip and fall, hang by the banister, or if you're a truck driver, you hang from the doors, you slip and fall. But more often than not, workplace injuries are repetitive in nature. In other words, you do the same thing every day for 8 hours, painting a ceiling, even typing. And this can cause, due to impingement, it causes wear and tear on the shoulder and ultimately can lead to small attritional rotator cuff tears. So what do you do? So when someone comes in and has shoulder pain, we want to know, how did it happen? Tell me your story. Is it a fall? Do you do the same thing every day, and then you just did a little bit too much over the last couple of months, and now it's just killing you, reaching to the overhead? On exam, is there bruising? Is there tenderness? Where is it? Where is the pain location? What tasks and what exams can I do that basically creates the pain? Initial shoulder evaluation is important to look at motion. Active versus passive motion. Active is the patient lifts their arm. Passive is I lift their arm for them. And so that's how you differentiate between a rotator cuff tear and frozen shoulders. So in a rotator cuff tear, the patient has difficulty raising their arm up. So their active range of motion is lost. Where passively, I can lift their arm up for them because they don't need their cuff. In an adhesive capsulitis or a frozen shoulder, actively, they lift up to say 120 or so, and they really can't get it up any higher than that because it's stuck. And passively, I can't push it up any higher as well. And that's how you differentiate frozen shoulder from rotator cuff disease. On strength, we're looking at abduction. Abduction strength is lost if there's a rotator cuff tear. Internal and external rotation. Interrotation is weak if the subscapularis is torn. External rotation is weak if the infraspinatus is torn. On neuro exam, you always look at, because that pain from cervical disc disease can create shoulder pain. The difference is that the pain is separate from motion. So in other words, if the pain is at rest and it also is associated with numbness and tingling, especially down into the hand, you have to think cervical. If the pain is associated with motion and effort, more often than not is from the shoulder, from rotator cuff issues. Specific exams. So adhesive capsulitis, again, rotational loss and elevation loss, both passively and actively. So in adhesive capsulitis, a patient has difficulty reaching behind their back. They just can't do it. And they lose rotation first before they lose elevation. So it's pretty easy to pick up as long as you touch the patient. AC joint, it's tender palpation directly in the AC joint. And so everybody in the world has AC joint arthritis over the age of 30 to 35. And the x-rays can often look terrible. So you really have to differentiate that purely by exam because the imaging does not help you there. On rotator cuff tears, small tears such as the supraspinatus, the patient may actually have pretty decent elevation, but they'll be weak in abduction and they'll be uncomfortable. They'll be a little have pain, but they can still get their arm into the overhead. With large tears, supraspinatus and infraspinatus, and this is worrisome because you don't want to miss these because these are the ones that can be difficult to fix. So these people, not only do they have difficulty elevating, but they can't externally rotate. So they're weak in external rotation. So if someone comes in and it's been a few weeks and they're still weak in rotation and in elevation, you'd lean to getting an MRI sooner than later. On subscapularis testing, this is the belly press where they can't press into their belly without the elbow falling to the side, or again, they can't reach behind their back. For instability testing, it's interesting that often these patients have good motion, but they're afraid, especially with anterior instability, they're afraid to get their arm up here. And if you push on it, push them backward like that, external rotation, they cringe. And if you lie them down and do the same thing, that's called the apprehension test, they'll actually fight you to do that. So that's how you pick up instability. On imaging, I usually just get a straightforward 3-view set, looking from the front, an AP, a Y view looking at the outlet, because that gives you an idea of impingement. That's a calcified coracoacromial ligament right there. That's a big bone spur. And on the axillary view, you get a good idea looking for osteochromiale, or if they have, it shows arthritis the best as well. On an MRI, and again, if they're weak, get that sooner than later, especially if you suspect a rotator cuff tear. Here's kind of a cool picture. The patient's biceps tendon, which should be over here, is subluxed into the subscapularis there. And I never get dye for a number of reasons. One, with the newer MRIs, especially the 3 Tesla and the 2.5 Tesla, you just don't need it, number one. Number two, 90% of the time you can see the pathology without it, and you also save a lot of money. So for me, especially if you're sending me a patient, don't worry about getting an arthrogram. So differential diagnosis, what goes wrong with the shoulder? What brings patients into the office? Well, adhesive capsulitis or frozen shoulder can be associated with other diagnoses, but it can also be something that really sets the patient back. So it's the great pretender, and clinical exam is the key because they lose rotation first. They can't reach behind their back. If they externally rotate and you push them quickly, they get a zing of pain. And so it's called a painful hard endpoint. I can almost, if I sometimes I'll tell people, say, hey, if something fell off the table over there, you reached for it quickly, what would happen? And they cringe thinking about that searing pain that they get that goes away in 30 seconds. And so what's the treatment? We do an intra-articular cortisone shot, and we always do guided shots, whether it's by ultrasound or by fluoroscopy, doesn't matter. But cortisone doesn't work unless it's in the right place. So it has to be in the shoulder or it's not going to work. And you can see there on the bottom just how red hot an adhesive capsulitis is. And it usually starts in that rotator interval, and these people are miserable. And so the good thing is that 90% of the time you can treat these non-operatively. Cortisone shot, we do wait a week, and then physical therapy, anti-inflammatories to augment, and usually this will calm the shoulder down and they get better. Instability. So this is not that common in the workplace as compared to rotator cuff disease, and this often is traumatic. They take a tumble or they hang from something and they sublux the shoulder. More common in the younger individual. So less than 30, what happens if someone dislocates, and this guy's got a huge Hill-Sachs lesion, that's what that is, and they're dislocated out the front. This is a left shoulder looking from back to front. So this is gonna be a challenging repair there. So what about treatment? Well, if they're under 30, you have to worry about it coming out again because, depending on how much bone loss there is or damage to the humeral head, as you see there, they have a higher chance of coming out. So in these people, you tend to lean towards surgical intervention sooner than later. But as they get older, so over 40, if someone falls, they dislocate their shoulder, actually the recurrence rate falls off to about 15%. And if you get an MRI, you don't want to treat the MRI because the MRI is going to be read as a Hill-Sachs lesion, Bankart lesion, labral tear. And if you jump to operating on these people, they get stiff as a board. So these people almost always, I treat them non-operatively, and they actually surprisingly get a little bit stiff. And 3 months later, they may need a cortisone shot because they actually get adhesive capsulitis, but they rarely come out again. So again, a non-operative treatment there. If they're over 50 to 60 and they dislocate the shoulder, what you have to actually worry about is not recurrent instability, but a rotator cuff tear. So in these people, especially if they're weak in rotation and elevation, I'll get an MRI, and generally, if they do need surgeries to fix the cuff. SLAP lesions gets a lot of press. And I trained with Steve Snyder, who described SLAP lesions back in the 90s. And bottom line is Steve operated on about 1% of SLAP lesions. So they've been vastly overtreated in this country. Europe thinks they're a joke. And so it's just something that the worst thing that can happen is you get an arthrogram MRI because about 50% of the time it comes back as a superior labral tear. And as we all know, the word tear on an MRI report is a license to kill. And so, again, avoid dye we don't rush to treat SLAP lesions because more often than not, it's just an underlying degenerative entity right here and has nothing to do with the patient's ongoing problem. And so again, vastly overtreated, especially if they're older individuals over 30 to over 40, you look elsewhere for the problem. It's usually a rotator cuff issue or arthritis. There's no reliable exam for a SLAP lesion, and surgical intervention usually results in poor results and a secondary adhesive capsulitis. So again, we tend to shy away from that surgery if at all possible. Rotator interval pathology. So this is interesting because this is something we do see often in the workplace, and this is that 5'5", 120-pound EMT who's carrying a 300-pound person down the stairs, and the other person kind of loses hold of the stretcher, and all of a sudden their arm is is basically yanked inferiorly, and they tear their coracohumeral ligament, which is a solid ligament that runs from the coracoid and covers the biceps. And so you can see the white there. It's almost like turning your ankle. They get a sharp pain, and it actually gets more uncomfortable over the next 2 days. And so this is the hanging injury or the traction injury is what I think of it as. And it's almost instability, but it's not, it doesn't quite get there. And so good thing is these hurt a lot, and they're undercalled. And so if you get an MRI with dye, you're going to miss this because the dye takes away this information right here. So again, on the MRI, the only thing you may see is fluid in the interval where the coracohumeral ligament, which is right there, is pulled off the humeral head. And you can treat these non-operatively. Usually it's a Medrol dose pack, quiet it down, and a cortisone shot if it's hot. Sometimes if the ligament is associated, the coracohumeral ligament, because it runs right here behind the biceps, it can also result in a partial cuff tear, and it's really red hot like this. Sometimes they do come to surgery, but more often than not, it's a debridement and possibly decompression if they have underlying impingement. So zebras. So again, if you treat shoulders, you got to remember there's other entities that cause shoulder pain. Cervical disc disease is probably the most common, and this is what I said before. They have pain in their rhomboid, the back of their shoulder. It radiates down into the deltoid region, but more often than not, there's also this element of numbness and tingling down into the first to the thumb and the first two fingers, and it can be positional. You can see here that's a big 5, 6, and 6, 7 disc. And this lady was really miserable. She ended up having surgery for that. Other zebras, Parsonage-Turner syndrome or brachial neuritis, unclear etiology, but basically it's demyelination of the suprascapular nerve. And it's basically not traumatic. It's more the presentation of really severe pain for about 4 or 5 days, followed by weakness. And you can see here on the MRI that there's demyelination of the nerve, which results in increased water content in the muscles, and that's basically the nerve is associated with these muscles is damaged, and then it remyelinates over 3 to 4 months. So they can't externally rotate and they can't lift. So it looks like a big cuff tear, but actually everything's intact. So just remember that when you get this funky history of sharp pain, 3, 4, 5 days, not traumatic, and then all of a sudden they can't lift their arm up, and that's treated by basically observation. And then thoracic outlet syndrome, you're all associated with that. And that's usually someone who has very poor posture. It can be post-surgical, and it's treated by basically stretching out the anterior structures, strengthening the posterior structures of the shoulder to improve posture. Rarely they need intervention. Actually, Botox has been really used of late to try to loosen up the structures anteriorly. And then finally, the big nightmare, of course, is when you get this completely unexpected tumor in the shoulder. And so impingement and rotator cuff disease. So this is probably the most common thing we all deal with, and it basically because whether it be traumatic or repetitive use of the shoulder, it's basically what is impingement? It's abnormal repetitive contact between the contents of the humeral head, the rotator cuff, and the biceps, rubbing against the container, which is the acromion superiorly, the coracoacromial ligament anteriorly, and the AC joint medially. And so type 1, 2, and 3 basically is just the shape of the acromion. Type 1 actually is unusual. Type 2 is the most common. Type 3 is calcification of the coracoacromial ligament. And so, yes, impingement is somewhat more associated with this, but it's more associated with a really thick ligamentous attachment in my mind. And the other thing it's associated with is the slope of the acromion on the AP view. And this is important. So here's the coracoacromial ligament, which comes, as we saw before, comes up from the front and inserts here on the shoulder. But as you get older, it can calcify and it forms this spur, which rubs, as you elevate your arm to the side especially, it rubs right onto the rotator cuff. And so this cuff tear is associated with repetitive trauma from that spur. And so on the lateral view, you can see how calcified that is. And so that caused that tear. And so the treatment. Step 1, anti-inflammatories and physical therapy to improve posture and job modification. Basically, try to keep them from doing repetitive overhead activity until it calms down. And more often than not, this or maybe a cortisone shot, this will result, especially early on in this process, in resolution, return to full duty, and not really having symptoms return right away. The problem is this tends to be something that over the years comes back, is that as the ligament calcifies a little more and there's a little less room here, the patient tends to have more and more episodes, and especially if their job doesn't change. And so They may come back again 3 years later, same thing, rest, cortisone, PT, successful, come back a year or two later, and this time the PT and the cortisone does very little, and at this point, that's when you go in and do the surgery. So basically, whether it's 1, 2, or 3 times over a prolonged period of time, it really comes at the point, surgical intervention is indicated at the point where the non-operative treatment just doesn't work. You give it 3 months if it doesn't work, especially if you have that history. And that surgery, basically you evaluate the cuff. You've got an MRI, so you know if it's torn enough. Debride, partial cuff tear, do a subacromial decompression or adjustment is basically what I call it now, and then address the cuff issues. And so what does it look like? So this is a left shoulder, and we're coming in with a spinal needle, and this is a red hot acromion covered by bursitis. And this scenario here is not a patient who has a big bone spur. What they have is they have poor control of their musculature, and thus the shoulders elevating up, and they do a lot of repetition. You see this a lot in like the Charles River labs, where people are just cleaning cages all day, again and again and again, and yet they don't have big bone spurs because they're young. And so here what you do is you clean out all the bursitis, and you thin out the coracoacromial ligament, but you're not taking out any bone technically. And basically it's almost like hitting the reset button, takes away the pain so they can do their rehabilitation. So contrast that with this scenario where the patient, actually I'm going to show you in a second, has a pretty good bone spur. So again, we come in, we're looking from the back, there's a left shoulder, rotator cuff below, acromion above, coracoacromial ligament. And so we come in and we're going to clean out the bursitis, which we did. The cuff is got a small tear right there, right? And we'll fix that later. And so here we're going to there's a couple of different devices. I use a Bovie, other people use an arthrocare, but basically we're going to peel the ligament off the calcified spur. So this is a pretty darn good bone spur right here, right there. And so that is impinging on the cuff, and that's that thick ligament. So we clean the ligament off, and then here's the spur right there, right there. And so now I'm going to come in with a burr, and we're going to burr off that ligament. And so that burr is 4.5 millimeters thick. So you don't really take much, in all honesty. All you want to do is basically make this smooth, take off just the spur, leave the normal acromion alone. And so we come across, it's much like mowing the grass. You kind of create an indentation, and then you progress across the shoulder until you get the spur off. And then I'd fix that tear. So what happens, again, when impingement kind of runs its course, you end up with a small or large cuff tear. Usually large cuff tears are more traumatic. So here's a small supraspinatus tear. This is an MRI, left shoulder, right shoulder, and that's a big spur, that's a large tear. And so with these, you don't want to miss the big ones. And so here, what are the treatment options? Well, partial rotator cuff tears initially can be treated the same as impingement. You treat them anti-inflammatories, icing, cortisone injection, rehabilitation. So unless it's a greater than 50% tear, I treat them all the same as impingement, and they can do just as well. If it's a full thickness tear, especially in an active patient, we usually lean toward repairing it, especially if they have to return to their job because they are going to have a significant loss of function, especially in the overhead. We avoid doing other things with rotator cuff repairs. The shoulder is a very unforgiving joint, so I never do labral and slap repairs when I'm doing a cuff repair because that just guarantees they're going to get stiff. I rarely take out the AC joint. I may take out a spur below the AC joint, but I really will take out the whole AC joint. And there was a recent study actually where they did a case control study where they took out the AC joint with a cuff repair versus not taking it out. And the people, and all these people had symptoms of the AC joint, but the people that did not take it out in did better. So I kind of follow that model. And then as far as biceps tenodesis, I don't routinely do that. I know a lot of people take the biceps. On every case, they do a subpec tenodesis, which makes no sense to me why you would take an arthroscopic procedure and make it open. But, you know, a lot of people do that. And the reason is those of us who do a lot of shoulders have now found the biceps tend to be an invaluable tool when you're dealing with revision situations or massive cuff tears. We can use that as a graft. So I never waste it. The other thing about arthroscopic cuff repairs, you know, I see all kinds of I do about a third of the cases I do a revision. So I see all kinds of different techniques utilized. And so 90% of the time I do my cuffs through just two portals, one in the back and one on the side. So I don't really need all these, and I certainly don't need 7. So, to me, it's like a bar fight. If someone gets stabbed 7 times versus 2 times, recovery is easy. So less is better. And so this is an MRI of an L-shaped tear, just to give you an idea. Sometimes we can differentiate different tears patterns based upon where the maximal amount of retraction is. So right here, that's where the tendon is. And as you go backward, the tear gets smaller because the infraspinatus is intact. And if you look, this is what it looks like. This is a right shoulder looking from the back to the front. And here, that's the biceps tendon. This is a tear that probably recently propagated because that interval split. And before that, they probably had a little attritional tear right there. So here, you fix the interval first, and then you fix the rotator cuff, and pretty straightforward. So that's an L-shaped tear. So on a reverse L, the supraspinatus often is intact. And so here you can see the difference. The tendon comes laterally, but it comes back toward us. So that's a reverse L, and the infraspinatus here is mostly intact. So here, we're going to fix the split between the supra and the infraspinatus there, and then we're going to put our anchors in, and that's what it looks like. So understanding tear patterns, what's it result in? Less tension on the repair. And why is that important? Because if you have a high tension repair, those are the tears that fail. So let's talk about that, failure. So we just talked about success. Now we're going to talk about failure. So what is failure? Well, I'll talk about that in a second. Revisions, been there, done that, what now? And again, this is a big part of my practice. So shoulders are unforgiving. You avoid the shotgun approach. So you don't just do everything you can in the shoulder to make more money. You do what's necessary. Adhesions are the #1 problem after rotator cuff or subacromial surgery. You can always do more, but you can never do less. And so I'm going to switch to a different talk where we're going to talk about revisions or rotator cuff repair. Okay, so been there, done that, what now? And so why do cuffs fail? Tension too much, technique too little. No, you have to respect the soft tissue. Tissue quality or loss. And this is a problem because the size of the tear doesn't mean much to me because if it moves, I can fix it. But if the tissue is really attritional, it won't hold a stitch, that's a problem. That's when we may have to do some type of grafting or augmentation. And capacity to heal. As people get older, unfortunately, they lose that capacity to heal, and we have to be careful to try to augment or encourage that as much as possible. So what is failure? Well, it's when the patient is still in pain. To me, it's 4 to 6 months out. If they're still in pain or they're stiff, if they're weak, you have to worry about re-tear. But a lot of people just have that pain and stiffness, and that basically prevents them from moving forward in physical therapy, getting into work harding, and getting back to back to work. So they have, and a lot of times they may have incomplete healing, but none of the above. In other words, you take a very large tear and they heal all of it about a centimeter, but they have no pain, they have no stiffness, they have fairly good function. Well, to me, that's not a failure. So you don't have to have complete healing of a cuff. You just can't have anything else above there. As long as they can move and they're happy, that's a good result. So post-op pain factors, again, too much done. Avoid labrum surgery, avoid AC joint surgery. This is a 50-year-old guy who went in for a decompression and woke up with a labral repair. That anchor is not in the right place, as you can guess, and they had a slap repair. And so I cleaned all this out, and he was an iron worker. So he came back for a cortisone shot pretty much once a year for the next 6 years. And then this arthritis progressed. So about 6, 7 years later, he ended up getting a shoulder replacement. But bad surgery leads to bad results. So stiffness is the most common problem after rotator cuff surgery. So here's a guy who had rotator cuff repair, and he's got a post-op frozen shoulder. That's all adhesions in there. We're going to release. And he has a re-tear of the rotator cuff as well, where the cuff actually healed to the acromion rather than to the tuberosity. And this is something important that I've seen a number of times, and I'll talk about that more later. And so why did people get stiff? They have too much bleeding early. The soft tissue is not respected. If they're diabetic, they have a higher incidence of postoperative adhesive capsulitis. If they have preoperative frozen shoulder, they're going to get stiff afterward. And the other thing is this, no passive range of motion in the postoperative period. I let my patients write and type right away because I want rotation. I want them with their elbow at their side. I want them to move back and forth because that'll help prevent this. So as long as there's some motion, they're not going to scar to the acromion. And I've gotten away from using a pillow postoperatively for two reasons. One, patients tend to just rest on the pillow and they don't move. So if they don't move, and I'm going to bring my arm down a little bit, if they don't move and they're sitting in the pillow, what happens is the rotator cuff is sitting up against the acromion. And if they don't move, the cuff scars to the acromion as well as the tuberosity. And then when they start moving, it's just a question of which interface is stronger. So if they don't have the pillow, that doesn't happen as often. And the other thing is we saw an increased incidence of postoperative blood clots with the use of the pillow. That being said, most people use it. I just don't. And so MRI, post-op revision, again, no gadolinium. And this is really important in these scenarios because you want to know where the fluid is, where there's issues with the humeral head. And you can almost always see the problem. So I can see those tears. There's usually an effusion. And so you definitely never need gadolinium in a post-op revision situation. And importantly, they don't do T1 cuts, which tells you atrophy. And so again, try to avoid that. Look for the 3D imaging of the acromion to see if there's impingement or bone spurs that were missed, or if the acromion is really thin because you worry about fracture. So non-operative treatment. This is the patient that's stiff, weak, but has enough elevation and rotation. You're not too worried about a re-tear. So I'll start off with an intra-articular cortisone shot under fluoroscopy if I want an arthrogram to check the congruity of the cuff, or ultrasound is usually fine if you just want to get rid of the adhesions and get them moving forward in physical therapy. I give them a week off from therapy and I send them back. And then we really, really push motion because motion in the shoulder is everything. So alter the PT, and if they're light duty, keep them light duty until they get their motion back. If it fails, and then the goals are to save the deltoid. The only thing you need if you have a massive failure of a cuff in the future, you can do a reverse shoulder arthroplasty, but to do that, you need a healthy deltoid. So I never make a bad situation worse. I never open a shoulder that's already had a major issue because all it does is make them worse. So this is a subacromial revision. This is a patient, she's about 8 months out, and she could rotate, but she couldn't elevate more than 120 degrees, and she was miserable. And this was a mini open procedure. So here, there's no landmarks, but basically, if you remember the subacromial images earlier, this is supposed to be a wide open space with the cuff moving back and forth. And you can see here, the cuff is scarred to the acromion. So I'm coming in and I'm basically staying right on bone and I'm releasing all that scar tissue. Now that we've cleaned it out, you can see the prominent knots down below. The cuff, although not beautiful, is intact. So I took out the prominent knots. I released all the scar tissue. And the good thing about this scenario is she can move the next day because we're not going back to square one. And these patients are also often very happy. So rotator cuff repair. So here's, in these situations, not only is the patient not done well, the cuff is retorn. So here we're kind of stuck. We've got to repair the cuff again. And when you're dealing with the revisions, the landmarks are different, the tissue's different, the anatomy's not predictable. So you repair as much as you can. You take out the old tissue and sutures. I don't usually take out the old anchors unless they're prominent because it leaves holes. And so what I do instead is I alter the anchors. So if the original anchors are PEEK or titanium, then I'll use a suture-based anchor the next time and I'll go right next to the old anchor. It's like reloading them. And if it's the opposite, then I'll use a more solid anchor, or if the bones are poor quality, then I'll use a titanium anchor because that's the most solid hold. And then I'll use the biceps if I have to augment. If I can't fix everything, I'll get a balanced partial repair because that can give them a darn good outcome. If I have nothing to work with, then there's a number of options, especially if they're older. If they're younger, I'll do a superior capsular reconstruction, but I've gotten to a different technique lately from that's worked just as well and is easier on the patient. If they're older and they have arthritis, especially, a reverse shoulder replacement may be indicated, especially, again, if they're arthritic. So here's a revision challenge. This is an orthopedic surgeon. I fixed his shoulder about 10 years ago. He went back, he was skiing, took a little tumble, and I think he tore his cuff right there. He's showing off. So what do we got? So this is a left shoulder looking for the back to the front, and that's his biceps there. Subscapularis is fortunately intact, but everything above is gone. So there's his cuff. It's basically retracted beyond the edge of the glenoid rim. That's his undersurface of acromion. That's a suture from his prior small cuff repair. So all of his super and all of his infraspinatus are off, and it's nowhere in sight. So here you think, oh my gosh, there's nothing you can do here. But in fact, it's not the amount of retraction, it's how mobile the tissue is. So here, the good thing is, it's like a window shade. This entire cuff was mobilized and could come back up over the head. And this is why you want to get to these sooner than later, the really big ones, because if they scar in, you can't move them. So here, he's basically a huge L-shaped tear. So once I repaired the interval, which is what we did here, it all came together, and then all we had to do is reattach his cuff to the head. So although a really big tear, because it was mobile and the tissue good, it was relatively straightforward.
Dr. Curtis, can you hear me?
Yeah. Yep.
You're still showing us the first part of your presentation with that one slide. The new slides for your next segment have not come on the screen.
Yo, shucks. Oh, I wish it said something. Okay. Huh. All right, hold on a second. That's weird. It says I am here. So you don't see the talk I've been giving?
No, we're still looking at the good, bad, and the mad slide since the second portion.
Oh, shucks. All right. Well, I'm enjoying it. All right, hold on a second. Okay, so you're seeing that. And it says I'm sharing my screen, huh? All right. All right, I'm going to stop sharing and then I'm going to do it again, see if that'll work, okay?
Sounds good.
Sorry. How's that? Now can you see it?
Yes, it's a different slide now.
Okay.
So hi, it's Joanne. So it's everything that you're seeing on your computer screen with all the slides lined up vertically.
Yeah.
This wasn't the case on your first presentation, just like Lynn said. It's just on this. Here we go. Boom. Okay.
All right. So I went through a lot of these already. At least you heard me, but you didn't know what I was talking about. But I will go quickly to the good stuff. We talked about what is failure, post-op pain factors, avoiding doing labral surgery, AC joint surgery, and why people get stiff, especially if they're diabetic or post-op adhesive capsulitis. So that's what this looks like down here. So there's a patient, right shoulder, post-op adhesive capsulitis, and a massive re-tear of the rotator cuff. Can you see that? Now you can see that, right?
Yes, we can.
Yeah, we can see it.
Okay, good. All right. And so here, this guy, he not only has a frozen shoulder, his whole cuff is up here. It's scarred to the acromion, and that's important, and I'll show you why later. And so post-op, again, don't get gadolinium if it's a revision, because you can see everything you need to without gadolinium. And I want to see these areas here. I want to see the end of the tendon, and I want to see atrophy. And if you put gadolinium in, you miss that, and you also save yourself $1,000. So non-op treatment, cortisone shot under fluoroscopy if you want an arthrogram to see if the cuff's intact, or most of the time we just do ultrasound in the office because it's quicker, and then we alter the PT and work regimen to get them moving, because motion is everything. Now, surgically, if it doesn't work out, if they fail conservative measures, then we go back, and again, I stay all arthroscopic, because the one thing you need if you ever have to do a reverse is a healthy deltoid. And so this is what I was talking about before, a subacromial scar situation. So this is a patient who 8 months out, never really got above 120 degrees, but they had decent rotation. And this is after cuff repair, and their cuff is scarred to the acromion. So they don't have that pretty completely open space that they need. So what we did is we come in and we release all that scar tissue, as you see there at the bottom, and recreate the subacromial space. And then we took out the prominent knots. And the good thing here in these scenarios is because the cuff's intact, they can move the next day. And it makes a huge difference. These are really happy patients. And it's amazing how 8 to 12 months out, you can still see this. And so if that patient now goes on to have another tear, this is what it looks like. So again, coming in on the bottom there, sorry. So coming in there on the bottom, that patient has a re-tear of the rotator cuff right here. And so we're going to refix it. But these people, it's a challenge to some degree because if the anatomy is not predictable, you have to alter the anchors. And I use the biceps to augment a lot. That's why I never waste the biceps. But if I can get a balanced partial repair, not even the whole thing covered, often that they do very well. If I can't, in the younger patient, I was doing a lot of superior capsule reconstructions, but now I have a new technique that's better. If they're older and they have arthritis, we'd lean more toward a shoulder replacement, a reverse shoulder. And so here's a huge tear, left shoulder, and that's the biceps there, the subscap's in the front, and it's intact, but his entire cuff is off. And this is important because this is a huge tear. All is supra and all is infra. So on the MRI, you wonder, could it even be repairable? But this is what I mean by size of the tear doesn't matter. It's the quality of the tissue and whether it moves or not. And so in this scenario, this is it's like a window shade. The entire cuff was retracted posterior and medially. But once we figured that out, look at that, the whole thing comes back. It just all rolls over the head. And he had good tissue as well. So once we fixed the interval split in the front there, then we got a nice repair. And then all we have to do is basically anchor to the head. So the size was daunting, but the repair was straightforward. So as long as it's not 3-4 months later, then it would have been hard to do this. So this is the real problem, and this will pick up the last few minutes here. Massive retracted tear, tissue loss, but no arthritis. And so what do you do here? So this is what we've been doing. We've been using the biceps as a graft. Why? Because it's free, it's strong, and there's numerous ways to do it. And so cuff salvage options, inside to biceps tenodesis. So what we're doing there is we're basically putting an anchor right behind the biceps and we're locking it into position. And what that does, it recreates what we used to do as a superior capsule reconstruction. In other words, the biceps runs from the glenoid. We put an anchor here and see how it runs from posterior to anterior. So think about that being locked in place. It prevents the humeral head from sliding out the front and allows the deltoid to work. And then if we can fix some cuff to that or around it, we get a really good result. And we're studying this really closely, and I can give you a little bit of the results there. And so a balanced partial repair is what we're looking at. So here we go. This is a right shoulder, massive tear, no arthritis, just the naked biceps, the cuff's way over here, and this infraspinatus and supraspinatus are off. So there's really not much to work with here. And so here, the first thing we're going to do is we're going to tie the biceps down. We're going to put an anchor in, and we're going to go around it and through it, tie it down, and then we're going to grab the tissue in the front there, the interval, basically to create this strut in the front that prevents the head from sliding forward and up. And once we do that, then we use it as a jump graft. So now we're tying the remnant of the supraspinatus, which there's no way that's coming back over there because it's just too big a tear and it's not mobile. So we tie it to the biceps using it as a jump graft. And then we're able to fix some of the infraspinatus, and we've recreated this balanced repair. And this allows the deltoid to work. And so we've looked back on these, and we looked at the first 40 with 2-year follow-up now, and had significant improvement in pain and function. And we didn't even cover the whole head. It's more about getting the balanced repair. So now, fast forward, and over the last couple of years, we've done something even more. So this is a very good example of the massive subacromial scar failure. So here, left shoulder, here's the rotator cuff, and it's completely healed to the acromion rather than over here. And the reason is the patient, again, probably didn't move postoperatively. They were in a pillow brace, which kept them abducted, and they didn't move. So the patient healed to the acromion instead of to the tuberosity where it was fixed to. And I see this a lot. And so this is what it looks like when you get inside. So here is his sutures, the cuff's way over there, and it's scarred up to here to the acromion rather than over here. So what we have to do is come in and we're basically dissecting the cuff. Here's the glenoid. Here's where we wanted it to be. And we're dissecting the cuff off the acromion so we can bring it from here back down to here. And so that would basically want to recreate what we can here. And again, this is something I see a lot. And so here we are. We're going to take out all that suture material, all the foreign material. We've released the cuff, and now we want to drag it laterally as far as possible. And so it's going to be a little challenging because it's not the best tissue I've ever seen. And so here's the view looking from the side. And so we incorporated the biceps. We got a little bit of the supraspinatus back. And then posteriorly, the infraspinatus don't have a lot to work with, but we're able to free this up as well. And so this is as we fix that in the back. So now we've pulled up what's left of his infra. So now, again, we've got a balanced repair. And in the last 2 years, we've been using something called the in-space balloon, which is an absorbable balloon that lasts 3 to 4 months. And what is the purpose? It makes it virtually impossible to scar to the acromion, and it protects the repair during that critical 2 to 3 month period where healing takes place. And so this is what it looks like right here. So we insert it and we fill it up with saline, and that's where it's filling it up. And you see, we're not fixing the whole cuff. And what this does is for that first 3 month period is it depresses the head. It's actually results in less pain too, because the patient can elevate and they don't have as much discomfort. So a lot of these people have had prior surgery too. So it's been very interesting to hear. Here's a guy who had, this is, basically a similar situation. Here he is, he's 9 months out. And he had just a huge cuff tear, just like this. And, he's in work hardening now, and we'll hopefully get him back, with some restrictions. But again, with these massive cuff tears, usually they would never get back to work. So if you see this request for an in-space balloon, that's what it is. It's an augmentation that protects for the first 3 months postoperatively. We've done 110 of them over the last 3 years, 50 with 12-month follow-up. And again, is it 100% effective? No, but this is a good line right here. So we've done actually 110, 50 with 12-month follow-up, and some with even more now, and only 2 have gone on to have a reverse shoulder replacement. So this is really good data. So in conclusion, avoid treating the MRI report. You focus on what hurts the patient and what's their lack of function. Tension is the enemy. So, if you do it right the first time, you don't have to come back, and you have to be kind to the tissue. That's what makes the difference. If they're not swollen, if they're not bleeding postoperatively, they have less chances of having adhesive capsulitis or being in pain, and thus will have a better result. You got to preserve the deltoid because that's so important. Enhance biologic healing as much as possible. We'll drill holes in the bone to let the bone marrow leak out. It's basically free PRP. And, you got to stay positive. As you well know, some of these people, if it's their second operation, they've been out of work for 1.5 years, and, they're very basically depressed. And so, it's really cool to give them a hope and an endpoint that we're going to make them better.